Do we have some Scheimpflug images also of that? Because I'm seeing this all the time, that the pentacam is showing some irregularities at the posterior surface. And if you then go into detail, you recognize there was some kind of a little bit of opacity somewhere in the periphery. And we know that Scheimpflug photography is very sensitive to any kind of opacities, especially when the information comes from the posterior surface. So in essence, I would rather go and look for opacities in that cornea and then start to think about the hidden, the family stuff.
But the take-home point of this thing is, when you have a thick cornea, first thing is check the family.
And just in addition, I would, in this case, ask the patient to come back, and then I do a high-resolution OCT. And if we still have a posterior float that is positive, then I'm starting to think about it. Because in many of those cases, we did that MS-39 from CSO in Italy, doing a high-resolution map with the OCT and with a resolution of 3 microns. And in those patients that I saw something in the pentacam, I didn't see anything a high-resolution OCT mapping.
But I think it's a great case.
Can I make a comment? Gitansha, have you looked at the endothelium? Did you do a specular? Because this could be a posterior polymorphous dystrophy with...
The endothelium was normal, the specular was normal.
Yeah.
SPM was done.
Okay.
Rohit, I just wanted to ask, I mean, the CBI, TBI indices, how reliable are they? I mean, for a refractive surgeon, can we base our decision on CBI?
I stopped it, sir. I have the machine. I stopped it. The reason being, I can't be sure whether I should do or not. And if the machine map has that red band there, and if I've done a surgery, that means I have done something with prior knowledge and willfulness.
Actually, so that was the reason for which we wanted to present these two cases. One eye is normal and the fellow eye shows changes in the CBI and TBI. In the second case, the TBI is totally normal in the fellow eye. So whether there is really an entity called unilateral keratoconus where one eye alone is affected and the second eye is totally pristine. And secondly, the relevance of doing this. Third is your interesting concept about this genetic predisposition. If it's genetically predisposed, you expect that it should equally affect both the eyes. How do you explain that it's thick corneas and there's such a large difference in the curvature maps?
There is a very nice article by Rabinowitz in American Journal of Ophthalmology. He looked at 12-year serial progression of patients with unilateral keratoconus. By around 7 or 8 years, most of the unilateral keratoconus have become bilateral. I don't know the exact number. It's just that one eye is more aggressive. When you have this abnormal type of presentation, like unilateral keratoconus, very thick corneas, other eye being very thick, the first suspicion here is that there is some genetic. You'd ask, why should there be a difference in the genetic? Because genetic should be in both the eyes. So Arka will tell you that you may have the genes in both the sides, but just like how your patient also, my patient developed those ectasias with locks, it's not the same. The modification of it is different. One side may be extremely more aggressive, the other side may be just be dull. And probably the protectant here is there is some kind of an abnormal corneal matrix out there which we have no idea why the cornea is showing so thick. So if you are ever doing a epithelial debridement and doing a cross-linking, I think Gairik is here. Whenever there is any interesting case, Gairik goes and gets the sample to the lab. So we'll be more than happy to look for collagen or any genetic markers. So next year, God willing, if you are meeting here, we should present this case. The question we always ask is, I think I've not answered it properly, is why should there be a difference if it's genetic?
Asymmetry, yeah. So asymmetry is known for a lot of genetic diseases.
You should keep it like a singer, like this.
Asymmetry is known for a lot of genetic diseases. It's not necessary, and we still don't understand why in case of certain patients there's symmetrical progression in both eyes and not in the others. Part of it could possibly depend on these epigenetic regulators that we often talk about, the balancers in the genome. So there could be some local de novo mutations that sort of alter the landscape there, which cause one eye to progress faster than the other eye. So you were going to say something?
Well, I was going to say something about the concept of unilateral keratoconus. There's no evidence that there is unilateral keratoconus.
So there is no evidence there's unilateral keratoconus.
No evidence that we have unilateral keratoconus. There's no definitive evidence that we don't, but it seems wisest to err on the side of considering it a bilateral disease. The fact that we have a new testing device that most of us are at a minimum concerned with the data it's giving us, we're then seeing many people turn around and say, because this device, which isn't very good, doesn't pick up the biomechanical change that we thought it would, therefore there's unilateral keratoconus. And I think that's a very dangerous direction to go.
So one of the things I would disagree from rubbing point of view in these cases is most of the children I see, they don't rub their eyes. The reason they don't, we ask them, thanks to you, eye rubbing is now a very, very important factor in each one of us. This was last year.
Wow.
And these children, most of the time, the problem with them, you can ask them which side the child sleeps. And the child, or I don't know whether it's a child or an adult, it depends on which side you sleep. And sleeping pattern also is very important as eye rubbing, because when you sleep, you put pressure like this. Or, that could also be a major factor in these children.
Actually, in our clinic, when we feel that there's an asymmetric keratoconus or one eye is progressing more commonly than not, when I've asked for history of eye rubbing, they've given history of vigorous eye rubbing for the affected eye. I've seen that fairly commonly, actually.
Yeah, I don't know, maybe France is a different country and I'm living in a different world. But me and my colleagues, because I would be afraid myself to be biased, but I'm very enthusiastically encouraging genetic studies, proteomic studies, but to me it's like piercing our eyes that if you look at the literature, from the beginning, there's always eye rubbing around keratoconus. It's up to 92% of children rubbing habits in a series published lately. In a paper in the British Journal of Ophthalmology of 1976, it was up to 75%. I would tell you that on my experience, when you have 100 patients coming for the first time with keratoconus, 73–75% would tell you at the first visit that they have a rubbing history, which precedes by far, like years, the incidence of the keratoconus. So out of these 25% who deny, if you have them 1 month later coming back to you, and if you educate them in the meantime, like when you wake up, pay attention. When you go to the shower, pay attention. When you go to work, when you drive, pay attention. When you're in front of the computer, pay attention. When you go home and you remove your contacts, pay attention. When you go to sleep, pay attention. You write this down, you give the list to the mother, the father, the husband, whatever, whoever. When you see this patient on the next visit, out of the 25 who denied eye rubbing on the first visit, probably 90% will say, you were right. Some patients call me the guru because I predict before they knew that they would rub that eye, probably in this fashion, and that they would sleep on the side they never really paid attention to. I'm not saying that, it's a 100% case because you can't prove it. This is why I call the no rub, no cone a conjecture. But I think a more scientific or maybe medically logical attitude would be to eliminate that possibility before thinking of a gene or a proteomics. I would tell you that it's.
I think if you tell more, tomorrow we'll have nothing to discuss in the debate.
Yeah,
because the whole debate is on eye rubbing.
No, but I know, but you have to accept that. But it's like also when you go, you can make an analogy with, I do it sometimes, a sunburn. Like you have a phototype for that. I would have a sunburn way before you do, if for the same level of sun exposure, but your UV light is what eye rubbing is to keratoconus. Now it's interesting to work on keratotypes because probably some are more sensitive to eye rubbing than others. But again, as scientists, and we've done some physics at school, how can you deform a tissue like the keratoconus is deformed in terms of morphology without the exert of a force? Because we have a model which again shows us that a soft cornea does not evolve like a keratoconus does. So the paradigm that a soft cornea becomes a keratoconus is wrong unless we explain why Marfan syndrome, who have ectasia from the aorta, have this flat cornea pattern, which is logical, in fact. The steep and flat is not logical if you believe that without the mechanical impact of something on the cornea can, on its own, evolve like that. I mean, if you explain this to me, I will say I was wrong, and I will come every year to say how I was wrong, and I will explain. But so far, nobody can explain really a process by which the cornea could be evolving like that. But if you put the aerobic, it's very easy, you know? It's not only mechanical, it's biological. If you take normal subject, and you know this better than me, they rub, they will have all those metalloproteinases expressed in the tears, the cytokine, which by themselves can induce the thinning, right? Plus the mechanical, then the thinning is obvious, and from the thinning and the softening comes the deformation, and that makes sense. But
I have a case for you, and then we will continue, because that case is linked to what you're saying now.
So wait, although I'm not agreeing with many things that Damien is bringing up, I was so surprised to read in January issue of Ophthalmology, there was this letter where they measured the intraocular pressure in rhesus monkeys, and they brought them to rub the eyes. And so they measured how the pressure rises in the eye during rubbing. They did it only with the fingers, not with the fist, which is even more. So who thinks that the pressure rises by 50 millimeters of mercury during rubbing? You. Who thinks that it's 100 millimeters per mercury? You too. Oh, you read that publication. That's not fair.
It's more.
It's more. It is 300 millimeters of mercury. So you are blowing up this eye in an immense manner. And we should not be surprised if you do this on a routine basis that this cornea deforms or the sclera deforms too.
So this is something interesting case. Damien, I think this is for you, this case is.
Okay.
And I asked my fellows to present this. They were a little shy not to present it. Nobody was willing, so I thought I'll do my job as a mentor and present it myself. This is a patient of keratoconus. The date may be wrong, but it's been stable for 4 to 5 years. He's not got any cross-linking done. And he comes back to me for the last 4 months. He says there's been a lot of progression, and this is his progression. Then I asked him, like what we always do, was there anything happening? Because being a male, he didn't say, if it was a female, then hormones, pregnancy, and all those things come. So I really he didn't say there was nothing which happened in his life. Then I said he may need cross-linking, but doc, you said for so many years it was stable and all that. Then I told him what really changed. Then he went out of the room. I'd already given him, because you can see there's a huge progression, already given him a date for cross-linking. Then he comes back again and he says, doctor, I need to speak to you for a minute. And he said, I got married, and that he came very close to me and said, in India, when somebody comes very close to you and say they're trying to tell you some kind of a secret, that room had nobody, but only me and him. And I said, fine, that's very nice. I thought that he's worried about should his wife know or something like that. You know, sometimes in a society is kind of complex. You know, you don't want to tell your partner. Then he said, see, after marriage, I developed a fetish. The fetish is every day my wife has to rub his eyes like this. I mean, this is not his photograph. We just recreated for 30 minutes. And 30 minutes she rubs his eyes, I believe, and then he falls to sleep. And it's a simple fetish. and he develops keratoconus. It's a JRS case report.
Something else.
You want to comment? I mean, this is not a made-up story, it's a true story, and I had nothing to say. Should I ask him to stop the fetish? Should I call his wife? Because if I do cross-linking, that fetish may continue. You want to say something?
You know, my first idea was maybe he became pregnant, because that would be another cause for progression.
His cornea became pregnant.
So, history is very important. You have no idea what they are hiding. You have no idea because, I mean, I kept asking him 3-4 times. Probably he realized when he went out that he should come and tell me something happening in his life. And I told him, even if you do cross-linking, this whole fetish has to stop. Professor Marshall?
I've been married for 47 years, and fortunately my wife is not a rubber.
Thank you, Gitansha. Good case. You would like to? Yeah. So we have some in-between plug-in cases. We have Professor Theo Saylor here, who is good in both the Schwind and Topolizer. So we have a complex case for him. Can you just show the topography? And he's going to show how he's going to make the cornea normal using his planner.
So can we present that?
No, not this.
Huh?
He needs the Schwind, right?
The Schwind.
You want the Schwind or you want the Topolizer?
No, that one.
This one. This one.
So this is is that a lady or a man? It's a young man born in.
It's a lady.
50s.
It's a lady. I'll give
It's
the
a
history.
lady. So, well,
This is a 50-year-old lady. She had LASIK done 22 years back, 1950. So you can calculate what her age. 60. Okay. So she got a LASIK done in US when LASIK came to US 25 years back. Probably at that point of time, they had done a very small optical zone, and very shortly she started developing CNVM in that both the eyes because of high myope. So she developed scarring. So she had a CNVM, she had a scarring, and she had a small zone. Practically, she knows more about topo-guided treatment than probably you, because she has done all her life. She has only done is research on this, to see that there's some hope for her, because she has extreme glare when she goes out, maybe because of her retina condition and also because of this. And the challenge now is she needed a cataract surgery, and with cataract with a small zone, this is a challenge. So, and Professor Saylor will show how he's going to plan if he has to do an enlargement or changing the zone, changing the optics of the eye.
We have to discuss it first. So, I mean, that is a classical way of, you can see here, it's about 4 millimeters, 3.5 millimeter in optical size, and it's descended by more than 1 millimeter, in essence, to 1.5. So we were surprised that she tolerated that kind of optics for such a long time. Can we go to the next? Oh, that was here. That was that one. Now, if you go into more detail and look how it looks like, how the optics look like, you have to go away from the sagittal, but go for the refractive equivalent, anterior power or posterior power, and then you can see that it's not that badly descended. You can see easily that according to the, if you go to the refractive, then you see that you do have a small optical zone, which is slightly descended, but still you need to compensate for that, say, untreated area in the mid-periphery. Now, in order to evaluate what you would like to do, you go then to the wavefront sonic evaluation, and you can easily see that she does have phantom images, she does have the point spread function is somewhat distributed, and for us it's always a little bit, it's always important to see what kind of refractive errors are in that area. So we have only the inner 5 millimeter evaluated, but you can see that the high order aberrations are 0.7 microns, which is a hell. That is a very high number. Low orders is only 0.53 microns, which is mainly due to the astigmatism. Now, if I could get this chart now on the planning of the for the laser treatment, can we do that?
Yeah, we can send it to the
because
planning.
then we would like to see how we just go forward, which aberrations need to be corrected. Export, yeah. So that is now exported. Cornea wavefront. Now she's exporting that map again, and then we can see how to go on. So here we are. So now